All right, now we are in the last section for Unit 11. So we are talking about musculoskeletal dysfunction. So this starts in chapter 48. So some important things that we have to remember as far as our structure. Our long bones can continue growing until age 20. We do see a secondary ossification. This is why we see such rapid healing, especially the younger the child is. Because there's such a rapid period of growth in the newborn period, we can have fractures, like a clavicle fracture that happened as a difficult delivery, heal in a matter of 3 to 4 weeks. It can happen very fast, okay? Bones are more porous and less dense. And then because of the rapid bone growth, as I said, we do see faster healing, but we may see that related to some growing pains if we're having a growth spurt. Okay, so we'll start with fractures here. You can see our different types of fractures here. So transverse, we're just straight across. Linear is going to be basically a line in the bone. Oblique is kind of at an angle. If it's non-displaced, it's still connected. If it's displaced, it's separated. Spiral, we're actually going to see that bone kind of in a twisting mechanism. Oopsies. Green stick, the bone is angled or bent beyond the limits. Okay, so you can kind of just see that insult here. And then for comminuted, we can see we've got some bone fragments and pieces of that bone there. Okay. All right, so often with our fractures, how we're going to work through our healing process involves immobilization, okay? So got two main types. We can have external fixation, which is what we often see, especially for less severe types of fractures. So this may be something as simple as a bandage onto a cast or a splint, or internal fixation, which means that we've got use of metal. Okay, so I can have an internal fixation that is closed. This is where I would see on x-ray, I would see the use of pins or plates to get my bone back to where it needed to be. Or I might have something I can see on the outside, which is what we're looking at for her leg here. Okay. All right, things to think about for your immobilized client. So table 48.1 on page 1422 goes through the physical changes related to immobility. Some of your big factors, though, are going to be related to skin integrity, to GI issues like constipation and obstruction. There's a decreased cardiac efficiency for patients that spend some time immobilized. And then we also have a decreased respiratory function. That's why patients post-op or patients who are going to have to stay in bed for some time get that incentive spirometer, because they do lose some of their vital capacity or their ability to clear fluids or secretions, right? So how can you help? You're going to change their position frequently. That helps with our skin integrity issues. High protein helps us with our healing. Suction we need. Hydration is going to be really important to have optimal health in basically all of our systems. INO is important to make sure our renal system is still functioning. DVT prophylaxis may look different depending on the patients. It could be something as non-invasive as the SCDs, or there may be something more invasive for a patient who's going to be on long-term immobilization, where he's on some type of clot busting therapy, especially if there's a high risk or a history. All right. Range of motion exercises, active whenever possible, maybe necessary to do some passive where the nurse is in control at some point. Diversional activities or play, because we can get very bored being stuck in bed. So we have to make sure thinking about the child's development, where they're at, what we can do to mentally stimulate them. Give them some choices wherever you can. We've talked about that. And then support the child and the family. Okay. A lot of that will focus on education. How long is this going to last? What are the that provide that anticipatory guidance, etc. All right, when you are assessing your fractures, you want to think about our 6 P's, okay? So we've got pain, pulselessness, meaning you cannot feel a pulse in that area. Pallor or pale, paresthesia is our pins and needles kind of feeling. Paralysis means that they can't feel or they are have no ability to move it. And then pressure. So what does it look like? Okay. If we had a situation where our patient was reporting pain, not uncommon because, the body's healing, there may be some effects of that trauma. But if I've provided pain medication or some type of treatment for pain relief, but my child is still complaining of severe pain that was not relieved by that medication, could indicate that I've got a pressure issue. All right. So this could be, or this needs to be an urgent matter for you. You need to really investigate. You're going to go and look at the circulation above and below the cast because there may be a bigger issue. All right, we could be dealing with something like compartment syndrome, where our fluid has been displaced and put severe pressure onto the limb, and drastically reduces the circulatory volume. That is a medical emergency. And we may have to do something very drastic at the bedside to restore that blood flow so that child does not lose that limb. All right, things to provide as far as your care. We always assess the skin before application. I need to know what it looked like before, so that I have that in mind as my baseline. Monitor the 6 P's that we just talked about. Elevate that extremity to make sure that we're getting adequate blood flow and prevent any edema that can increase our pain, decrease our circulation, and decrease our healing. We're going to provide patient and caregiving teaching that would include to keep the cast clean and dry. So if it's our arm, we have to wrap that before our child can get in the bathtub. If we're dealing with a harness like this, or I'm sorry, a cast like this, keeping our perianal area clean and dry is going to be really important. We'll teach our parent about the 6 P's. We want them to report any hot spots on cast or pain that's unrelieved after trying some modifications immediately, as we already discussed. And we want to teach our child to keep things out of the cast. A lot of times when casts are removed, providers will find some interesting things in there. Sometimes it's just out of curious nature, because kids are just curious by their nature. Or sometimes it was an instrument. There may be some scratching that's happening deeper than that child can reach with his hand. And so he uses something inside that cast. All of it is going to increase our risk for infection, which is why it should be part of our teaching. All right, we're going to talk about hip dysplasia. So we call this DDH, or developmental dysplasia of the hip. This is something that we start investigating from our first assessment with our newborn, okay? May have seen this in other literature called congenital hip dysplasia, congenital dislocation of the hip. DDH is the more effective and more recent title. Okay, so it basically follows into 3 abnormalities. Okay, so in the most mild form, we have a shallow acetabulum. So that's where our the head of our femur fits into our hip socket. It's just not deep enough to really hold on to that. Okay, we can have subluxation, that is the largest percentage of DDH, or we can have an actual dislocation. Okay, so with that shallow acetabulum, often what has happened is that there was a delay in the acetabular development. We would be able to see that through some osseous hypoplasia, through possibly a biopsy. Okay, with that subluxation, we're looking at stretched ligaments that actually cause the head of that femur to be partially displaced. And then with the dislocation, the femoral head has actually lost connection with the acetabulum, sorry. All right, so what are you going to see? In the infant, you're going to see a shortened limb on the affected side. You're going to see restriction in the abduction or adduction on the affected side. If you were to turn that baby over, you may you may see unequal gluteal folds. What you might have seen on your own child or maybe in the clinical setting is the Ortolani and Barlow test. I got some pictures for you right here. So basically with Ortolani, we pull those legs down and then we abduct them with external rotation. And then with the Barlow, we kind of push them back up. And so it all kind of, the tests happen at the same time. But what you would hear if it was a positive find is that clunk. And that would tell you that we do have some dislocation, okay? In our older child, the affected leg is going to be shorter than the other. You may also see some telescoping of the piston mobility on that joint, meaning that because it has, it's not sitting correctly, we may see some issues with that joint. We may see that the greater trochanter is more prominent. Might note some marked lordosis if our DDH is happening on both sides. And you may also see a waddling gait if it is on both sides. So what are we going to do about it? So early detection gives us the best potential for or the best prognosis, which is why it's part of our newborn assessment. We wanted to detect this early on. Not really a great picture, but here we're looking at our Pavlik harness. Your textbook has a much better picture. But essentially this is going to be worn continuously until the hip shows stability on ultrasound or based on the clinical findings. Usual treatment's about 6 to 12 weeks, depending on how advanced that dislocation is. All right. This child will need to go in every 2 weeks to make sure that the harnesses are in proper alignment because the baby does grow so much in that period. We have to make sure that we're holding that placement right where we need to be. All right. The parent would be instructed to loosen the straps when bathing, both to clean the child effectively and also to check the skin underneath to make sure we're still having good circulation. All right. If the issue is not found until the child is older, it doesn't happen until the child is older, like when he's walking, we may have to use the spica cast. It's also used if we've tried the Pavlik harness and it was unsuccessful. Okay. So hygiene is essential. You can see our little slit here to allow the child to have evacuation of both his bowel and bladders. But you do have to make sure that the skin is clean and dry. All right. This cast is going to get changed every 6 weeks for about 3 to 6 months, or as long as we need that treatment. Okay. The big point for you to make for your parent when you're providing that education, there should be no attempts to walk, to balance, to stand, etc. when that cast is on. Okay. Even if that child was walking before, we need to make sure that that is not happening, because that is going to put unnecessary pressure in that hip area. All right, this is a picture of Talipes equinovirus or club foot. This deformity can happen in so many different directions, where your foot pushes inward, pushes outward. There are several variations of the club foot. The one that we're going to focus on is this Talipes equinovirus. So that is downward and inward. Okay. So our treatment is going to be based on how severe our situation is. So we could simply have positional club foot, which means that the baby grew larger than the uterus allowed for, or was in a position that didn't allow for the child to really extend those joints. So really all that we need here is some stretching, okay? Maybe some casting. Congenital clubfoot most likely requires surgery, but we're always going to start with serial casting first. If serial casting doesn't work, then we could go forward with surgery if we have to. Can also be syndromic or part of one of those disorders that we've talked about, like VACTERIL. Remember that L in that is that limb deformity. So that could be our component here. Okay. As far as diagnostics, this is typically something that we can see pretty evident once that baby is born. Sometimes we can see it on prenatal ultrasound if it's a pretty great deformity. Okay. Treatment for that serial casting usually is about 6 to 9 weeks. Child does have to go in weekly to get those casts changed out based on his growth and kind of where we're at in our stretching process. May have to do that heel cord release if the tightness is based in that area. Okay, if that doesn't work, we may try something called Ponseti shoes, which is where the shoes are actually connected to each other. My little brother had to wear these. They're connected to each other and they keep the foot stretched in the direction that we want to. He never required surgery. The shoes were enough for him. If that doesn't work, then we move on. We have to do some surgical intervention to correct it. Oops. All right, now we move on to idiopathic scoliosis. So we know that this means that we have a lateral curvature and spinal rotation. So we see our normal patient, we see our scoliosis. The best way to diagnose this is to have the child take their shirt off and bend forward and try to touch their toes. And we would be able to see that difference there. So recommended screening occurs between 10 and 12 in girls and 13 and 14 in boys. Can't be diagnosed at any age, but is most commonly diagnosed during that pre-adolescent growth spurt. Okay, you can see our potential for treatment. If there is a less than 10-degree angle, we don't need to do any treatment. We'll just keep an eye on it. 10 to 25%, we may not do any treatment if it's not progressive or it's not changing. 25 to 45% angle, I don't know why I said percent, 25 to 45-degree angle, we're going to do some bracing, and then beyond that 45-degree, we're going to need surgical intervention. It is important to note that bracing is not curative. It is possible for it to kind of misalign, may mean that we need to do the surgical therapy after all. If it's beyond that 45 degrees, we do need to do that surgical intervention. So we can do spinal fusion, would help us realign and straighten that spine. This is a very, very painful procedure, okay? So pain control is going to be of utmost importance. As far as moving your patient, you're going to log roll them to try to not put any undue pressure on that spine, let it heal. Prevention of skin breakdown is going to be very crucial as your patient will be mobilized for a little while and also increases that risk for infection. And then getting this child up early helps with a better prognosis long-term. All right. The next thing we're going to talk about is osteomyelitis. So this is an infection inside the bone. Often this is secondary to some type of trauma, like a puncture, can be a surgical contamination, or there was an infection in tissues that were near this area, okay? Diagnostic comes from 5 to 7 day history of pain, warmth, decreased range of motion, and the fever. The MRI is going to give us the best or the most sensitive diagnostic information. All right. We're going to give IV therapy of antibiotics based on the afflicted agent. From that, we can move on to our oral antibiotics, which are going to continue for quite some time. Pain control is going to be crucial in this treatment as well. And then while we're in that acute phase of illness, we want to avoid weight bearing and really let that area heal. All right, the last condition we're going to talk about is juvenile idiopathic arthritis. This is seen by chronic inflammation. Often the things that we think about with arthritis, where we've got morning stiffness of our joints, things that we think with like older adults as far as arthritis is kind of what we're seeing here. The symptoms begin before the age of 16 with a peak onset between 1 and 3. So really just as that child is starting to walk. Don't really understand what causes this, which is where that idiopathic nature comes from, but it is thought that we have some genetic environmental components. Right. There is no cure. This is going to be a lifelong therapy treatment process for this patient. Our goal is to control pain and think about optimal function. Okay. Optimal function means that we have as normal experience as possible. So we promote normal growth. We use both active and passive range of motions as necessary. We treat with medications as necessary. We do have to be careful depending on our age. We really want to focus on that non-pharmacological management as well. So PT, overall health, having some type of exercise that doesn't put a lot of stress on the joints, like swimming, for example, and heat therapy in periods of exacerbations can be very helpful as well. All right, that is the end of module 11, or unit 11. So I will get all of this posted. If you have any questions, feel free to send me an email, and then we will come back on the 12th and we will do neuro in person. Okay. I hope you all enjoy your Labor Day weekend. You definitely deserve a nice break. All right, bye-bye.